Hello, everyone. Thank you so much for taking the time out on this Sunday afternoon to be a part of this clinic program, navigating the mental health system. We thank you so much for being here. Just before we get started, I would like to, sorry, give me 1 minute. So just before we get started, I'd like to start with the land acknowledgement. The clinic team deems it important to acknowledge the stolen land on which we reside. In light of the topic of our clinic today, which is about the mental health system, we deem it important to acknowledge the institutional racism that exists in healthcare towards Indigenous and Black people. I acknowledge that the land that I am on is the territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is home to many diverse First Nations, Inuit, and Métis people. Since we are virtual, I would like to acknowledge that we are also all on sacred land that is subject to many treaties, and encourage people to look up the individual land that you live on to see where the original treaty is from. Just some clinic housekeeping. We are recording this session just so that individuals in the future, if they would like to have access to it, they can. So if you don't want to be recorded, please make a note of that and don't put your camera on. We will be having another clinic next week, speaking about caring for yourself while caring for others. And this is something that is very, very important so that individuals who are caring for others don't get burnt out. Because you can't help anyone else if you yourself are stressed out. Also, please use the chat for questions, or you can send them directly to me. I'm the host. Or if you would like to speak directly to our facilitator, you can do that as well. There'll be 2 sections for questions, one midway, and then one at the end of the session. Just remember, if you'd like to speak directly to the facilitator, that you will be recorded. So please, please keep that in mind. As I said, we'll be stopping for questions just before the break, which will come halfway through the presentation or partway through the presentation. It'll be about a 5 to 7 minute break. We'll see how far we've gotten through the presentation at that point, and I'll let you know. And then lastly, I would just like to let you know that we will be mentioning, just a trigger warning, we will be mentioning suicide along with other mental health conditions during this presentation. If you need to, please take a moment to step away if this will be an issue. There will be another trigger warning on the slide that we do specifically speak about suicide. And lastly, disclaimer, this information is for educational purposes only and is not intended to replace the advice of your healthcare practitioner. So please keep that in mind. Okay, so right now I would like to introduce our speaker for today. Nadeisha Pinnock was born and raised in Toronto and is of Jamaican heritage. She has worked in the mental health nursing field for over 10 years. She has gained experience in supporting adults, children, and transitional aged youth affected by mental illnesses and disorders to navigate the mental health system. As a mental health and addictions nurse, she is passionate about the provision of equitable and accessible mental health and an advocate for racially and culturally competent healthcare, which is so needed in Ontario and in Canada on a whole. In addition to her current position, she is also an active member on a number of organizational committees, a CMHA Peel Board member, so that's Canadian Mental Health Association Peel Board member, and the owner of a virtual bake shop, Sweet Homage. I think if I'm saying it incorrectly, Nadeisha, you will correct me when you come on screen. Caribbean inspired desserts. Outside of the office, Nadeisha is pursuing her dream of becoming a published novelist, where she is applying her knowledge to reach Black youth and reduce the stigma surrounding mental health. Ladies and gentlemen, Nadeisha Pinnock, I'll turn it over to you now. Thank you for being here.
Thank you so much for that warm introduction. You were pretty much spot on. Some people say homage, some people say homage. I think it's all good either way. But again, thank you again for that warm introduction. Hi, everyone. I'm glad you're all here. Like she said, my name is Nadeisha Pinnock, and I am happy to be presenting this topic, this very relevant topic to you. And I hope that you walk away from this presentation feeling more informed about mental health. More importantly, I hope you are able to apply some of what you learned today in your daily lives. So we're just going to go ahead with the presentation. Today, I'll be providing an overview of mental health and Ontario's mental health system. Participants should be able to describe the continuum of mental health by the end of this presentation. This includes understanding the differences between mental health and mental illness. They should also be able to identify and understand components of the Mental Health Act in Ontario, inclusive of capacity to provide consent and make decisions. We will also focus on the impact of racism on our mental health and well-being, while also discussing how race impacts your interaction with the healthcare system. Participants will be able to identify early signs of mental illness. And finally, they should be able to describe how to access support using primary care as an entry point. I just also want to make a disclaimer, but while I'm presenting, I can't really see the chat. So if there is any raised hands or anything like that, if someone can kind of let me know, and then I will act accordingly. Okay.
I'll let you know, Nadeisha. And just to let everybody know, I've changed my name in the chat. It's host. My name is Camila. So you can send your questions to me.
Okay, thanks. So we're going to start by taking a quick poll. This should show up on your screen, I'm assuming. I'm going to actually shut my presentation mode down so I can see. So the question is, do you feel you have mental health? So just answer the question, yes or no. It's anonymous, so I can't see who's responding what. So just to give you a little bit of reassurance. So I'll give you a few moments to answer that question. Okay, I see a few more trickling in. I think there's a couple more. I think there's one more person. I don't know if it's... So far we have most people saying yes. I have a few people saying, some saying no. And then I have the big question, which is, what is mental health? Which we'll get to. So I'll share the results here. As we see, a large majority said yes, which is great. Some people said no, and some asked, what is mental health? So we'll definitely get to that throughout the presentation. Let's go back here. Okay, so according to the Canadian Mental Health Association, 20% of Canadians will deal with a mental illness at some point in their lives. But just because someone is suffering from mental health issues doesn't mean that they have a mental illness, and I'll get into that. So what's the difference between mental health and mental illness? So as shown on the diagram, mental health exists in all forms. You can have, as you can see here, good mental health despite having a mental illness. You can also have poor mental health and have a mental illness. Finally, you can have poor mental health despite not having a mental illness. So I'll give you a couple of examples. So we'll start with having good mental health despite having a mental illness. So you are diagnosed with depression, which is a mental illness. However, you exercise daily, you attend therapy regularly, you follow up with your doctor who monitors your medication, you get good sleep, you eat healthy, you are thriving at work, you have good relationships with friends and family, and you're doing the best to prioritize your self care. So, despite having a mental illness, you're doing everything you need to do to maintain mental wellness or good mental health. Another example would be poor mental health and not having a mental illness. So I'll give that example. Your workplace is stressful. You rarely take a day off. And then on top of that, you get into a car accident, which makes you temporarily anxious to drive on the highway. You may have experienced a traumatic event, but with time, the anxiety goes away and you're able to drive on the highway again. You don't seek any support about the stress you're experiencing. This is just an example of having poor mental health despite not necessarily having a diagnosed mental illness. Research has shown, however, if you experience repeated incidences of trauma, so it could be multiple separate events or the same related events, such as like being in a long-term abusive relationship or being exposed to violence for long periods of time, you have a higher chance of developing the mental illness post-traumatic stress disorder, or PTSD, which requires counseling support and at times medication to treat various symptoms such as trouble with sleep, anxiety, and so on. To have poor mental health and a mental illness in this example would mean you are diagnosed with PTSD and you're not taking care of yourself to promote recovery, such as you may be self-medicating, which would mean like drinking alcohol or misusing supplements or misusing prescribed medication, smoking marijuana to cope, and other more stronger substances, staying in negative environments, drinking caffeine to avoid sleep, self-isolating, and so on. To better help people understand mental illness, both in personal life and in the workplace, the Mental Health Commission of Canada developed a mental health continuum model that illustrates the spectrum of symptoms people experience or exhibit when dealing with mental health issues. So as you can see here, it starts at, you can go on the continuum being healthy, and then you can go all the way to the other side of the continuum being ill. And it doesn't, there's no way of experiencing it for everybody. There's no textbook way. So some people might be healthy for long periods of time, and then they may regress to being injured or ill, and then they might become healthy again. And like we talked in the previous diagram, it is very much possible to be diagnosed with a mental illness, which would bring you to that spectrum of illness, maybe temporarily, or as we may call a crisis. But then as you receive the treatment and following through with supports, you would then go back to the other side of the spectrum, maybe being a bit more healthier. Okay. One of the most important things that the continuum model shows is that mental health is not binary. It runs on a continuum, like I said. We all fall somewhere on the continuum, and we can move back and forward throughout the lifespan. By looking at our mental health as a continuum, we can learn how to recognize early signs in ourselves and others. It also helps to minimize the stigma, and it can help to prevent us from moving further into the spectrum. So I'm going to go back to the poll question. So let's define mental health. Mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and act. It also helps determine how we handle stress, relate to others, and make choices. Mental health is important at every stage of life, from childhood and adolescence all the way through adulthood. And I will use the analogy of, for example, our physical health. Everybody has physical health. It's not even a conversation. Most of the time, when people talk about health, they're usually implying physical health. How's your sleep? How's your eating? Do you get any headaches? How is your ability to hear, see, touch, smell, walk? Those are all physical health categories, and it's an umbrella term. So similar to physical health, mental health is also almost an umbrella term. It's inclusive of our overall well-being. Mental illness is a behavioral or mental pattern that causes significant distress or impairment of personal functioning. Such features may be persistent, relapsing, or remitting, or occur as a single episode, as I talked about in the previous presentation or in the previous slide, as I mentioned about the person who had the car accident and they were super anxious, but they got over it, right? So that's a single episode, whereas persistent would be someone who might have post-traumatic stress disorder or depression, schizophrenia, psychosis, etc., where it's something that is occurring throughout the life, despite becoming maybe more manageable over time. Like I said, mental illness may require some form of intervention or support from external systems like doctors, therapists, medications, or facilities. So racism plays a significant role in our mental health and well-being. Research shows racism has negative impacts on mental health of Black communities and affects racialized communities such as Indigenous individuals in unique ways. We need to look at mental health from a post-colonial lens, which means looking at it based on the history and consequences of colonization. So when European whites came into a country or they brought people into a country that they may not have originated from and essentially created a life here on the impeachment of people who may have already lived here. So that's colonization, essentially. Historical traumas such as slavery, social exclusion, residential schools, the 60s and 80s scoop, which I won't get into too much detail here about, but in a very, very, very simplified nutshell, the 60s scoop and 80s scoop was when Child Protective Services, or in Canada, we call it CAS, Children's Aid Society, was apprehending Indigenous children at an exponential rate, separating families unlawfully, putting up children for adoption. If you go online and you look up 80s and 60s scoop, you'll see a lot of narratives and stories, true stories of experiences and the trauma and fallout from the 80s and 60s scoop. So anyway, these events increase our risk to experiencing mental illness at higher rates than our white counterparts. Even though the models of mental health care in Canada are evolving and improving, the practices are still based in Eurocentric treatment practices and policies that result in excluding racial and cultural groups. Examples would include the education curricula of mental health workers like nurses, doctors, social workers, etc. It's very based in white and westernized models, which excludes a large group and diverse group of populations around our country. Also, few people from racialized communities are in senior positions in healthcare and are directly involved in creating new policies that support the needs of racialized communities. So if you are working in healthcare or you work in a school or anything of that nature, I would task you to look around at your organization and see who's in the front lines versus who's a manager versus who's your director or VP of your organization, CEOs, who sits on your board of directors, who's making the decisions. And you may see that it's very much skewed and a lot of us are excluded from those tables. Few programs offer cultural specific or competent services to racialized communities. And we want to discuss and note that diversity in cultural competence or cultural humility is another term, is not the same. A lot of organizations state they value diversity, but research has argued that that's not enough because it doesn't address the systemic issues deeply rooted in healthcare. It is more like a band-aid solution. If a majority of the diverse staff are front lines, like I previously mentioned, but none are managers or board members, institutional racism will rarely be challenged, or certain practices or policies would never be changed. Pathways to treatment will still be oppressive and negatively impact our mental health. A glaring example of this is the overrepresentation in the criminal justice system. So if you do have a chance to look at the statistics or Google it, you'll see that a lot of Black individuals, especially Black men, are introduced to the psychiatric or mental health system through the justice system. And that's usually their first engagement or encounter with it, which, if you could imagine, is not the best way to explore your mental health and well-being. In addition, according to Across Boundaries, which is an organization, a multicultural organization in Toronto, failure to effectively diagnose and treat members of racialized groups and Indigenous populations can increase healthcare costs through repeat visits to care facilities and unnecessary hospitalization. But I just wanted to note that there's more attention on this topic that's occurring in research and healthcare. Organizations are beginning to understand the importance of race-based data collection. An example would be the Black Experience Project, and this was carried out in 2017 in partnership with Mount Sinai Hospital in Toronto, where various leaders from healthcare providers, nonprofit organizations, education, and so on, they collectively came together to discuss the health equity challenges within the healthcare system in relation to Black Ontarians. And also in 2021, the Center for Addiction and Mental Health, known as CAMH to most, launched a report, Strategy to Dismantle Anti-Black Racism. And the strategy includes 22 action items to decrease anti-Black racism in CAMH, the organization, by 2022. So now I'm going to play a video for you. I just want to note that this video is difficult to watch, but it's necessary narrative of one Black man's view of mental health and racism. The content of this video is sensitive in nature and triggering. So if you feel that you need to walk away or mute your speaker, please do so. And you can come back when the slide changes. That would be your indication that the video is over.
I was always taught to be strong in this world. Told to never let my guard down because at any moment I could be attacked without a moment's notice, that my skin made me a target. Skin that has persevered through many trials and tribulations, from seeing my mama raped by landlords, to my father being beaten and stripped of his manhood, to my brothers and sisters being separated into jobs for this bigger system. My skin has always been under attack. Yet somehow we prevailed through it all. Through all the lynchings, literacy tests, new Jim Crows, war on drugs, the gentrifications, police brutalities, food deserts, mass incarcerations, we survived and adapted and pushed to change because our very existence depended on it. Our very existence depends on this Black strength. Strength that has carried us for decades, but is undermining an important aspect of our humanity and feeding in on itself. Being strong all the time took away our ability to speak about our weaknesses, our sadness, our mental illnesses. This silence is killing us. On top of that, we lack proper mental health care access and endure mistreatments by medical professionals who cannot relate to us in their practice. On top of that, we stigmatize mental illness to preserve this place of our strength, damaging ourselves, and among Black children observing a spike in suicide rates, because they may feel that their place in heaven is way better than their place here today, because when Black life isn't valued enough for professional help, adequate housing, or even breathing, life here degrades in value in comparison to life after. Black bodies, strong Black souls are floating through the wind, seamlessly letting go. Strong Black bodies are screaming for help, but suffering in silence and being socially and systematically being put on quiet. Black souls are strong, but we do need help when we do fall through the cracks. That is why I want you to know that you can patch things up with me. All right, we can kick it back like it was a drive-through movie in the 1970s. We could get some help from people who actually understand us, refute our standards of stigmatizing mental illness, and fight against the structures that chronically misdiagnose what this really is. Fight against the racism that brings up our mental health issues and lowers our treatment options, bringing us one step closer to seeing no other option. I want us to see that we have a way to heal this wound that has been widening ever since day one with no means of contracting. I want us to know that the seed that we sow today is the harvest we reap tomorrow. And when we finally reap, we can find peace in these moments, noticing that the danger isn't gone, but we finally have a place where it feels like it is. The grounding of Black bodies.
So we're back. And, put in the chat, feel free. This is a safe space. We're here to have conversations. We're here to express our thoughts and feelings. And I would love to know what you thought about that video. I know the first time I watched it, it was profound. It really left an impact on me, and I really did want to share it here in this presentation. And I hope you found it just as resounding and impactful as I did. So we're going to talk about now the impact of racism on our mental health and well-being. How does racism impact our mental health on an individual level? Race, until recently, has been overlooked as a factor that contributes to the health and well-being of an individual. Literature has called for racism to be a social determinant of health due to racial biases contributing to poor mental health outcomes. So the World Health Organization defines social determinants of health as the circumstances in which people are born, grow, live, work, and age, and the systems put in place to deal with illness. Some examples of determinants include age, gender, socioeconomic status, education levels, and early development. The determinants are also used to identify and analyze health inequities that exist within Canada's health policies and services. Patients who experience racism are more likely to report mistrust, dissatisfaction, poor communication with healthcare providers, and a reduction in continued engagement after the initial presentation. Studies have shown that children of racialized communities experience significantly longer wait times than their white counterparts. So we're going to talk about the layers of stigma. So stigma, simply put, is a negative stereotype. And you may have heard this concept before, people having stigma or stereotypes, especially when it comes to race. Black men walking down the road, white women walking up the road, may see the black man in the night, may cross the street because she feels unsafe, because there's this stigma that large black men equal crime, unsafety, thugs, so on. That's an example of a stigma. These kind of conversations also are interwoven in mental health. And there are various levels of stigma, and we'll go through them using this diagram. So the first one is self-stigma. So these are the negative stereotypes you experience toward yourself. For example, in terms of mental health, I'm just being dramatic. I don't need help. I just need to pull myself together. Then you have stigma by association. What negative stereotypes do you hold about those closer to you? Now, this one is usually a defense mechanism. You don't want anyone to view someone you care about in a negative light. So you may minimize the severity of their mental health needs until it's unavoidable or there's some form of crisis. My sister isn't crazy. She's just going through something, but she'll be okay. My cousin's just rude. He doesn't need any medication. How will the world view you based on your connection to somebody else? The next one is social stigma. This is the most discussed. This is the most common. How does society stereotype groups? So we see it in movies, the way people may avoid eye contact with people experiencing homelessness in the subway, the glares you may get if your child is acting up in public, when they start to while out at Winners or Walmart, you get those little side eyes. Those are all examples of social or public stigma. Finally, we have structural stigma, which is like the framework of all stigmas. It's the governing bodies, the institutions, and so on, who create the rules which informs how we see people with mental health, and especially racialized communities intersected with mental illness. So mental health stigma in the Black community can be traced back to slavery. Slave owners didn't see slaves as humans, therefore not able to experience depression or other mental illnesses. Slaves would compensate by identifying their mental illness as stress or feeling tired. And these terms are passed down and have negative associations to being weak. In racialized communities, the consequences of mental health stigma is compounded by adversity such as poverty, racism, and discrimination within policies and institutions, resulting in more consequences. Racialized communities more commonly delay, avoid, or drop out of mental health treatment in comparison to their white counterparts. Black people don't go to counseling, but we're beginning to. That's something I want to acknowledge. I'm seeing a lot more conversation around going to counseling, which, I'm cheering on in the stands. Denying or concealing of mental health symptoms. So, I'm a do me is sometimes a symptom of, removing yourself from social groups, not connecting with people like you used to. Those can be symptoms of depression, but sometimes we're looking at it as, I just like to be myself. Introverts for the win. Nothing wrong with being an introvert, but if you were an extrovert your entire life and all of a sudden you want nothing to do with your social groups, you're in your room a lot longer than usual, there's a conversation to be had there. Internalized racism further worsens self-stigma, leading to feelings of hopelessness, or no one will care. Family members minimalize signs of mental illness until there is imminent crisis. Self-medicating through substances such as marijuana and alcohol is usually the first line of defense. And then self-diagnosing and self-treatment using herbal teas, supplements, and please note there is a place for this, but there are regulated holistic practitioners that you can access, and there are options available for you to be able to make sure you're taking these supplements safely. Because just because it's natural doesn't mean that it doesn't have side effects. So now we're going to get into the meat and potatoes of this conversation. How does one navigate the mental health system? Because it can definitely feel overwhelming, but with the right tools, we can make it a little bit easier. The most important thing to do is to educate yourself. Consult with credible people, access research-based sources for information. This includes mental health professionals, such as social workers, psychologists, psychotherapists, mental health nurses, family doctors, public health professionals, and so on. It's going on mental health organization websites such as Canadian Mental Health Association, Kelty Mental Health, and so on. You will also have to unlearn a lot of thoughts and behaviors that reinforce stigma and reduces help seeking. Early intervention is essential. That is important. Research shows that it can reduce the severity of mental illness and psychosis. And in psychosis studies, starting medication early protects the brain from degrading and increases chances of recovery. Finding a family doctor you can trust is also super important. And we'll get into that shortly. Seeking out informal or formal advocates and being open to trying various approaches and treatments, even if this means getting a second opinion, can also decrease the challenges with accessing or navigating the mental health system. Finally, therapy isn't a bad word, and it's shown to help people build the tools they need for their recovery journey. And you don't need to just access therapy when you're in a crisis. Sometimes it's also accessing it when you went through a crisis and you are feeling better and you just want to debrief and review, and also to hone in on the skills that you may have already collected. Okay, so the next thing is going to your family doctor. So we need to find a doctor for yourself that suits your needs. And it's being very patient, because I know sometimes this can be a little bit of a journey. You might go through a couple doctors, or you might have to wait a little bit of time before you get access to the right doctor. And there are resources available for that. The first one is called Healthcare Connect. And this is an Ontario-based resource. And you should be getting a toolkit or a handout with the contact information for Healthcare Connect and all the other things, the resources I may be discussing throughout this presentation. But if you could do a quick and dirty Google search of Healthcare Connect, something will pop up. And there's two options on how to register. And you can either register online, or you can call the number on the website, and the person, what we call a healthcare connector, would assist you with finding a family doctor within your area. Now, the caveat with all of this is if you are already registered with a family doctor, they won't be able to do anything until you contact your previous family doctor and de-enroll from their caseload. And also you may want to collect some of your patient records so that you can pass it on to your new family doctor. And most family doctors have a fee for transferring of records or collection of patient records. So with Healthcare Connect and with and all the resources in Ontario, there are multiple means in which of connecting to a primary caregiver. And we call them that because essentially they are the first line of defense. They are the gatekeepers to accessing all other specialized services like psychiatry. And there are various means of doing that. And I'll try to go through these in this presentation and as quickly as possible and as simply as possible. So the first one is family health teams. Family health teams are healthcare organizations that include a team of family physicians, nurse practitioners, registered nurses, social workers, dietitians, and other professionals who work together to provide healthcare for their community. Family health teams provide more services and a wide range of health options, especially for people who don't have a doctor. Another mode of receiving primary care is through community health centers. So examples are listed there, like Black Creek Community Health Center, Rexdale Community Health Center, Shout Clinic, Parkdale, and there's many more. Ontario has 101 community health centers, and they provide healthcare and community programs and services designed specifically for the communities. So CHCs are mandated to serve populations that have traditionally faced barriers in accessing healthcare services, including homeless individuals, seniors, refugees, new immigrants, and low-income people who are experiencing low income, as well as Black communities. CHCs are also mandated to provide services at no charge to people without a health card, which is awesome. They deliver medical services under the same roof as health promotion and community programs. CHCs can employ a team of physicians, nurse practitioners, nurses, psych counselors, community workers, and other professionals to offer a wide range of services. Examples would include checkups, immunizations, diabetic foot care, nutrition counseling, needle exchange programs, youth leadership training programs, and the list goes on and on. There's also anti-racist initiatives and other programs to promote tolerance, cultural diversity, and acceptance of minority groups, and outreach to isolated seniors. And then we have nurse practitioners. So nurse practitioners are nurses with advanced university education who work both independently and in collaboration with other healthcare professionals to provide patients with quality healthcare services. Nurse practitioners can diagnose illness and injuries, perform physical checkups, order and interpret diagnostic tests, provide counseling and education, and provide treatments and order some procedures as well. They can also refer patients to other healthcare professionals and specialists and prescribe some medication and order certain blood products and oxygen. And then also we have Aboriginal healthcare access centers that are scattered across Ontario. And they, again, similar to CHCs, they're mandated to provide culturally competent or culturally sensitive services to the Indigenous communities across Ontario. Finally, we have GP psychotherapists. So GP psychotherapists or general practitioner psychotherapists are doctors, family doctors mostly, who also receive training to practice psychotherapy, and they are covered by OHIP and are free of cost. It's kind of a one-stop shop, and there aren't a lot of them in Ontario, unfortunately. But if you are lucky enough to get a GP psychotherapist, it is very valuable because they do understand the intersections between healthcare and mental health care, and also be able to provide you with counseling support during your appointments. So I just want to ensure how everybody's doing. I see there's some chats, and I will get to them right before the break. I see some messages in the chat. I just wanted to acknowledge that. So we're just going to go over going to a new family doctor. So the first thing to know is when you receive a family doctor, whether it's through Healthcare Connect or you want to call some manually, you just Google a couple in your area and you're just doing cold calls, which you are allowed to do, to people within your region and seeing who's accepting patients. The first thing you want to do is interview your doctor. And I know that sounds odd, but when you think about it, this person's going to be responsible for your treatment. And you want to ensure that this person, who's now the gatekeeper to many of your healthcare needs, knows what to do, right? And knows how to help you. So examples of questions you may ask, and I'm not going to go through them. You can see them here. I'll just go through a couple. Is a very simple one is, do you have any expertise in mental health? It seems like a simple question, but a lot of people may overlook it or assume, hey, you're a doctor, you should know about mental health. And some of them, to be quite honest, they don't know as much as they should, or they're not up to date with the most recent research or treatment approaches to be able to support you. So it's an important question to ask. And with that, I would say a next important question is, are you comfortable with prescribing or monitoring psychiatric medications? The reason why I label this one as very important is because a lot of times your doctor will be responsible for monitoring medication. So even if you do get a consult with a psychiatrist, the most of the times a psychiatrist may provide very time limited interactions with you and then do a handoff back to your family doctor, who would then be responsible with continuing your treatment. They are capable of doing that, but you just want to ensure that they are feeling comfortable with it, and that the doctor you do have on that's providing your care has history or experience with doing so. And there are some other questions, and these list of questions will also be included in your handout. Okay, so now we're going to talk about preparing for an appointment. So when booking an appointment, inform the reception or doctor that you need extended time to discuss your needs. The average doctor's appointment is usually about 15 minutes, maybe 20, depending on the doctor that you might have. So you want to ensure that you book a time where they're able to give you a bit more attention. And usually the average is that they may provide is a half an hour, maybe 45 minutes, maybe an hour if you're lucky and you have an amazing doctor who's able to clear off that time. But the key thing here is to make that known up front that you need that extra time. The next thing is to set some goals for your appointment. Write some stuff down. Why are you going to see the doctor about your mental health? What has changed? What are your questions? What are your needs? Planning ahead is super important, and that goes with setting some goals, writing down your thoughts and questions in advance, and bringing your notebook with you to the appointment so that you can keep and take notes during the session. The other piece you can do in preparation is sending your doctor information in advance. So some doctors have faxes. I'm aging myself, but people still use fax machines, and some people have what we call patient portals. And there's different softwares and portals and platforms that they may use for that. But some doctors have that where you're able to confidentially send information to your doctor via that platform. So you would want to discuss that with your doctor. So we're just going to continue with that conversation. Oops, I think I skipped something. Sorry. So the next thing is honestly describing your mental health concerns. So the thing that I would tell you to walk away with is thoughts, feelings, behaviors. Those key three things, and also major life changes, those four key things will help you be able to guide your thought process. Because sometimes when you get to the doctors, you forget things or you get nervous. It's also what we call white coat syndrome. You see the doctor and you feel like, okay, well, maybe my symptoms are not as bad as I thought. I don't want to waste this person's time. So you tend to minimalize things and you skip over things, and then you walk out of the appointment feeling unfulfilled. So the key thing to remember is thoughts, feelings, behaviors, and major life changes. And I'll go through each one. So for example, with thought statements. So it's writing or expressing statements that describe changes in your thought process that is abnormal from your baseline. Examples would include, I can't seem to focus on reading or computer games like I used to. I can't remember details of lately. I think people talk about me more so than before. My thoughts are moving so fast, I can't slow them down. I'm having thoughts of hurting myself. I think people are following me. When I think of eating, I feel sick. Those are all examples of thought based challenges or descriptions. And then with feelings, some examples of feeling statements may be, I have been feeling less motivated to do things, or I always feel like crying. Or on the opposite end, I feel numb or empty. I don't feel anything at all. I feel like I'm on autopilot and I'm just going and going. Small things tend to get on my nerves or upset me more than usual. And then you have behaviors. And some examples of behaviors would be like, I'm always struggling to go to sleep at night. I'm always late for work or doing my work or school. It's hard for me to get out of bed in the morning. I'm suddenly failing all my classes. I used to be an A student, and now all of a sudden I'm getting C's and F's. I may lose my job because of my declining of performance. I'm very impatient with my kids and my partner. I stopped working out. I started smoking. I started drinking more. I spend more money than usual. And those are all examples of behaviors that may have not been there before. So the key thing is to remember what has been different, what has changed that you feel has a negative impact on your mental health and well-being that you think would be important to discuss. And then finally, major life changes. Somebody passed away, maybe you're getting married, because it sounds like a joyous occasion, but sometimes that induces a lot of stress. Or it may also trigger some traumas that you may not have explored before or didn't even know was there. So these life events are also important to mention to your doctor. And also, it's important to mention these things because some physical illnesses may mimic mental health symptoms. So it's important to get a full workup to determine the root cause. So, for example, physical health issues that can mimic psychosis, so like hearing things or seeing things that are not there, suddenly having delusional thoughts, like delusional thoughts are beliefs that other people, it's not based in fact. That's the best way to explain it. So, an example may be, I'm a superhero. And I don't mean that in a motivation kind of way. Like we all feel like superheroes sometimes. We nail a presentation and so on and so forth. Yeah, we feel on top of the world, but it's a persistent, strong held belief system that other people don't believe with you, or they don't share that same belief with you. And that those type of symptoms could be present in physical diagnoses like HIV, severe dehydration, complicated diabetes, Alzheimer's, or long-term alcohol use. So it's important for you to mention those symptoms, and then also for us to do a differentiation of understanding: is this physical, or is this more related to mental illness? And it's also important to schedule regular checkups with your doctor. And finally, if you don't trust your doctor, it's important to have that conversation with them or finding another one. And it's accepting the growing pains with that. Um, so at the end of your appointment, it's important to book a follow up. Ask your doctor, when should I come back? And be specific. Should I come back in 2 weeks? Should I come back in 1 week? And it's making an appointment before you leave the office. Any referrals or recommendations that he shared, you may want to ask for a copy of those referrals or confirm that they have been sent and what you should be looking out for. Who should be calling you? Should you be calling them? And so on. Once you leave, it's to reflect on the appointment. Do you feel that your needs were met? Do you feel like you covered everything that you needed to cover? And if there's something that you forgot, don't be afraid to call or email your doctor through that portal and have follow-up questions, because that's what they're there for. People forget all the time. We're human, right? And like I mentioned before, some doctors have these sites like InViduCare, which are platforms where you can share confidential information. Now, in terms of ending a doctor-patient relationship, and you can end it for many reasons. You could be moving out of the city. Your doctor might be a little more old school that you like. No offense to the doctor, but they may have a different approach in providing treatment that doesn't jive with what you need. So you may have to end your relationship with them. And like I mentioned before, you want to be direct. So you're going to have to call the doctor's office and ask to be taken off their list or roster of patients. And once you make this request, you may have to incur a fee to transfer your files or to collect your files physically to carry to your new doctor. Now, in more serious circumstances, if you need to file a complaint against your doctor, and filing a complaint could be for various reasons. It could be because your doctor violated your privacy. You may feel like your doctor shared information, your healthcare information, without your consent. This is a very relevant conversation for young adults and teenagers who have a shared family doctor with their parents, and the family doctor may share very private information with parents. And that's a very gray area, which we'll get into later on around age of consent. But if you as a teenager or young adult feel that may happen and you are upset about that, you can definitely make a report about that. So you would inform the Information and Privacy Commissioner, and that information is also in the handout. And you would go through a certain series of steps to make this report. And one of them may be a mediation or reconciliation session with your doctor if you choose to stay with that same doctor. And then more seriously, if there was reports of misconduct or harassment, or the doctor acted unprofessionally, you can complain to the College of Physicians and Surgeons of Ontario, CPSO. And there is a process around complaints. If you go on their website, which will be also in the handout, it will tell you step per step what you should expect from that encounter, that complaint report. And this site is also a really great one to show you the steps on how you would go about making a complaint, and it's also in the handout.
Yes. We're about to start the second half of today's presentation, navigating the mental health system. So right now I'm going to ask that Nadeisha share again, and she's going to continue her presentation on navigating the mental health system. Just a reminder, if you have any questions or comments, you can direct it to me in the chat. I'm the host, Camila, and I will direct it to Nadeisha at the end of the presentation when there's a spot for questions and answers or anything like that. Okay, thank you. And again, I'm going to turn it over to Nadeisha.
Awesome, thank you. I just want to make sure you see the slides and the right slide deck. Is that what you guys are seeing right now?
Yes, the Mental Health Act. That's what we're seeing right now.
Awesome. Okay, so we'll continue. So the next step, or the next stage of this presentation, we'll be discussing the Mental Health Act. So the Mental Health Act in Ontario allows physicians to assess and also to detain patients for a set period of time. It does not allow healthcare to force treatment onto an individual. So this is a process to determine if someone is incapable or making treatment decisions, and that's a completely different process. So in this particular case with the Mental Health Act, you still have the right to refuse medication and treatment. So the Mental Health Act determines specific areas. So it allows to determine admission process, treatment decisions, patient care, and it also allows for emergency treatment where there has been a heightened risk to self or others. So the Mental Health Act sets out the powers and obligations of the psychiatric facilities in Ontario. The Act also outlines the power of police, officers, and justices of the peace to make orders for an individual who meets certain criteria to undergo psychiatric examination by a physician. Patient rights are also referred to, including procedural details such as like the rights to appeal and the consent and capacity board. So like I mentioned before, if you are capable of making decisions, and I'll get into that shortly, you still have the right to refuse treatment if you are not at imminent risk of harming yourself or others. And that's where that Emergency Treatment Act would come into play. So there are different criteria. So there is a criteria for voluntary and informal and involuntary admissions. And again, I'll get into that shortly. So this Mental Health Act actually protects the patient. So one must receive formal rights advice in certain circumstances. Again, I'll get into that in the future part of the presentation. But this Mental Health Act shows that the patient is the one being prioritized throughout the processes. So despite even emergency treatment taking place, it is very time limited. So the emergency treatment can only happen, as I mentioned before, if the person is at risk of self or others, and then it's not enforcing medication onto somebody. It's mainly just detaining someone and also being able to provide them with counseling and support in a locked psychiatric facility most of the time. So we'll talk about the Mental Health Act. So the Mental Health Act are rules for determining capacity and treatment decisions, admission to care facilities, and personal assistance services. So a person is capable with respect to a treatment admission if the person is able to understand the information that is relevant to making the decision about the treatment, admission, or personal assistance services, as the case may be, and able to appreciate the reasonable, foreseeable consequences of decision. So I'll break that down. So essentially, you go to the hospital. The doctor says, you know what, you're not doing very well. It seems like you may have some depression. We're going to admit you for further assessment. And I'll get into that piece shortly. And then they may say, you know what, I strongly recommend you to take a medication. and you would ask for more information, and the doctor will explain to you what the medication is for, what the potential side effects are, et cetera, et cetera. Now, based on that information, you can now make a decision, and you may decline to receive that medication. And they have to accept that fact. They can't force it on you because you are capable. They have assessed that you are capable of understanding the information that you received and then making a decision based off that information while understanding the potential consequences of you refusing or accepting the treatment. So there is no age of this. There's no age of consent for this. The rules for capacity essentially remains the same. So age can and should be taken into account by healthcare practitioners when assessing capacity and when assessing capability. And as a child matures, this thought process should deepen. So when you think about a 4-year-old compared to a 16-year-old, their ability to absorb or understand information will 100% change, and their capacity to make consent will also theoretically mature or evolve. So while the child ages or the patient ages, they become more determinative, and then the doctor has to take that into consideration. There's still certain, once a student or a patient reaches a certain age, the same protocols around the Mental Health Act will remain the same. And then we would have the conversation, of course, around the substitute decision maker if the person, whether they're a child or an adult, are deemed incapable of making decisions or providing consent. And that's an entirely different process, and it's a lengthy process. So it's not something that would happen in 5 minutes. You go to the doctor and the doctor says, oh, well, you're not capable, you need a social substitute decision maker. There would need to be a bit more questioning and assessments to determine that case. So we're going to talk about one of the first more commonly discussed forms or pieces of legislation or paperwork within the Mental Health Act. So this would be the Form 1. So if a physician believes a person is at risk to self or others, they can write a Form 1. The person may remain in hospital for up to 72 hours while they receive an emergency assessment. If the person leaves without authorization within the 72 hours, police can be notified and apprehend the patient and bring them back to the hospital. When the form is signed, the patient receives a Form 42, which notifies them that they are on a Form 1 and the reason they're on a Form 1. The patient should receive the original copy of the Form 42 as soon as the Form 1 is signed. Now, once that 72 hours is in process and the person is not found to be a risk of self or others, they could be, and that 72 hours lapse, they can leave the hospital if they wish, even if it's against medical advice. If the psychiatric team finds that the person is continuing to be a risk of self or others, they may be held in the hospital under another form in the Mental Health Act until they're found safe to leave. So in certain circumstances, after the 72 hours are over, some patients may have the insight to say, you know what, I think I still need some help and I want to stay and continue to receive treatment. And that would be being placed and staying in the hospital for voluntary reasons. And I'll get into if you are having to stay there involuntary for longer than 72 hours shortly. So this is the example of a Form 1. This is exactly how it looks. So any doctor or anytime someone's saying they're on a Form 1, this is what it looks like. And as I mentioned before, this is only filled out by a physician. So I won't go into it too much detail because you'll never have to fill anything like this out unless you're a doctor. And this is based on the physician based on their own observations and the reports from the family and loved ones. And even the physicians and communities will determine if the person is in question is being at risk. So a family doctor can also fill out a Form 1. So it doesn't necessarily have to be a doctor at an emergency room. So if you, for example, take your loved one to a family doctor and they're being assessed and they see, okay, this person is at risk of hurting themselves or others, they can fill out a Form 1 and have an ambulance or police come and take the individual to hospital for further treatment or assessment. So this is, again, just the rest of the form for the Form 1. And as you can see, there's various criteria that has to be filled out in order to determine if someone would be placed on a Form 1. So as you see, the key ones that we mentioned here is serious bodily harm to self or herself, serious bodily harm to another person, substantial mental or physical deterioration of himself or herself, or serious physical impairment of himself or herself. So an example of mental or physical deterioration is suddenly you find people doing things that they weren't doing before, and it's putting them at risk. An example would be a deterioration in self-care, not showering, not eating, hoarding and barricading themselves in their rooms, walking outside in the middle of winter with no shoes or with shorts, no jacket, for extensive periods of time, and even the latter, which is walking out in a heat wave in like a Canadian Goose jacket, down jacket, fully covered and clearly dehydrated and in need of support. So those are some rationale why someone might be placed on a Form 1, and they have a history of mental health, which is also a big determinant of Form 1. Now, please note, you don't technically already have to have a diagnosis of mental health in order to be placed on a Form 1. This may be your first engagement with the system, is being placed on a Form 1 because you are in crisis and it's a newly onset or mismanaged mental illness that you are experiencing or a loved one may be experiencing. So now we'll get into a Form 2. So what is a Form 2? And this is where caregivers and loved ones come in. And this is something that you might have to deal with or work with in the future. So if you are concerned that a family member is at risk to themselves or others, you can request a Form 2 from the Justice of the Peace. This form allows police to take the person into hospital for assessment. At the hospital, the physician will assess the person and see if they should be placed on a Form 1. So the Form 2 is just for you to get them to the hospital, and then they will be assessed, and the doctor can determine if they need to be assessed for further. So the 72-hour hold. So Form 2 is valid for 7 days. It is not, as I said, not detainment, it's just apprehension. So it's literally giving the police permission to find this person in question and pick them up and take them to the hospital. So one thing that we can discuss or is important to note, and I'm cognizant and sensitive to this matter, is it's a very difficult thing to do. It's very difficult to go and file a Form 2 on a loved one, especially even if you strongly believe they need the support. And it can negatively affect the relationship you have with a family member. However, the important thing to keep in mind if this were to happen is that the safety of your family members or loved ones or those around you is the most important thing. The police may also take the person to hospital if they or someone else have seen the person behaving dangerously and as a result as a mental health concern, or if they have a Form 1 already. So there could also be a history of the person having a mental health concern, and you would have to pull out a Form 2. So I'm going to go through the Form 2 process in a little bit more detail and walk you step by step. So as I mentioned, if you are concerned about a person and you need to file a Form 2, you're worried about them, you contact the Justice of the Peace, okay? Then what you will do is you can go on Google or any other of those websites, and you're going to download the Form 2, and that's also going to be included in your little package that you should receive. And you're going to fill out the Form 2, which I'll get into in the next slide. And you're going to bring this form unsigned as to the Justice of the Peace. So you're going to make your case to the Justice of the Peace, and if the Justice of the Peace thinks that it is a case, they will sign off on the Form 2. And that Form 2 will now be taken to the police division where the Form 2 was signed. So it's not based just on, of course, it's based on the location, but you want to ensure you go to the nearest Justice of the Peace closest to your home or the location in which the jurisdiction in which the person lives. So because it's going to be taken to the nearest police station, who will now be responsible for apprehending this person. So now the police execute the Form 2, and you can have that valid for 7 days from the day that it was made. Now the person listed on the Form 2 is taken to the ER department for a physician assessment. And it could be a psychiatrist, or it could just be an ER doctor on staff for the day. And based on the doctor's diagnosis, the person could be placed on a Form 1 for further assessment, or the person could be released from hospital. And this may be against your wishes. So it's really important that you make a very strong case and you provide the most detailed and honest information possible to the provider so that they can make an accurate assessment. Because, we know people, and sometimes if someone's not ready to receive treatment, they're very good at creating a narrative that they're perfectly fine. They can hold it together for a couple of hours to go through the assessment. And for some cases, it might be difficult for the doctor to assess and see that they need more support than they're maybe presenting firsthand. So it's important to fill out this form as detailed and provide as much information as possible. So this is the form 2. So the first part is, of course, filling out your name and your address and that information. And then you're also going to fill out the name and the address of the person that you feel needs help. And if it's the same address as yours, you're going to put the address again and the contact information. Now, in terms of the sections you may fill out, so if you see on the form, there's a part A and there's a part B. You fill out the part A if the loved one can make their own healthcare decisions. And you fill out the sections you check anything that applies here. So as you see here, there's threatening or attempting to cause bodily harm to themselves or herself, has behaved or behaved violently towards others, has shown or is showing lack of competence to care for themselves, serious bodily harm, and so on and so forth. So in that, as I mentioned before, the examples of lack of competence to self-care and serious physical impairment, as I discussed previously, wearing shorts and no shoes in the middle of winter, not eating or drinking for an extensive amount of time, and locking themselves in their room. Now you fill out part B if they're not able to make healthcare decisions. So this is something that would already be in place. So if you, for example, are already their substitute decision maker, or if they're found incapable of treatment, you would fill out part B. So, for example, as I mentioned before, your loved one would already have a mental health diagnosis, and by history they get better when they are receiving treatment. And if they're untreated, they may cause harm to themselves or others, and not be able to take care of themselves. And you feel, and more importantly, that they're suffering from the same mental health concern that they were historically, you would fill out part B. Okay. So this is just part B continued. So once you fill out this form, you're going to bring it to the justice of the peace, who will review the information provided. You will have to show your loved one's situation fits the behaviors described in the form. You can do it in writing. So there's another page to this here. You can do it in writing on the form. And you can also provide what we call evidence of the information. So, for example, if they have a mental health diagnosis already, understanding their mental health history, any time spent in a psychiatric facility in the past, any history of violence towards themselves or others, any history of suicide or comments or threats they've made about suicide, or any signs that they're unable to take care of themselves. And you can attach any relevant documentation, such as hospital records, psychological assessments, police reports, and so on, in order to further inform this being approved. So once this is affirmed and the justice of the peace approves this, then you guys will sign the form, and now it's enacted. It's active for the 7 days. So as I mentioned before. So essentially, it's answering these questions. Why did you check these boxes? What evidence do you have? So I'm going to take a step back. We're going to go back to the form 1. So say you did a form 2, your loved one goes to the hospital, the doctor assesses them, and they determine they need to be on a form 1. They are apprehended, they brought to the inpatient unit, they're there for 72 hours. The 72 hours lapses, a doctor does an assessment, and they feel like they still need more time for treatment and being detained. So this is where a form 3 will come in. So the form 3 needs to be signed by a different doctor than the form 1. So usually it's the psychiatrist on the floor of the unit. And the form 3 can last up to 14 days. Okay. So the patient is given a form 30, and this informs them that they are now placed on a form 3 and why. And this is usually completed by the MD or the doctor that filled out the form 3. So when this happens, they are given an appointment with a rights advisor. So the rights advisor comes to the unit, and the job of the rights advisor is to explain the patient's rights. you're placed on a Form 3, this is why, and these are your options. So the options is usually either to agree with the Form 3, so you know what, I do think I need a little bit more time, or the patient could appeal the Form 3. And if that's the case, they would schedule an appointment with the Consent and Capacity Board in order to advocate their case. So they'll go up in front of this board and they'll argue why I shouldn't be on a Form 3. I don't think I need to be here anymore. So the Form 3, as I mentioned, goes for 14 days. And once that 14 days is lapsed, you can now issue a Form 4, or you can allow it to lapse and the person is now voluntary again. And the Form 4 lasts for 30 days. And you can continue to apply or add a Form 4 for 2 months at a time. And then, so the second one you add would be for 2 months. And then the third one you add would be for 3 months, so on and so forth. Okay, so now we're going to discuss what a Form 21 is. So a Form 21 is given to a patient when it deems them incapable to consent to treatment, manage their own property, or management of their own healthcare information. So when the person receives a Form 21, they're given a Form 33. So similar to the Form 3 and the Form 30, the Form 33 is to formally notify the person that the physician deemed them incapable to consent to their own treatment, manage their own property or finances, or managing the release of their own healthcare information. So once you receive the Form 33, you'll be immediately tasked to find a substitute decision maker. And the substitute decision maker can be a parent, a loved one, someone you trust and has your best interests at heart. So it doesn't technically have to be a family member. So if you're unable to find a substitute decision maker, or SDM, after making a reasonable attempt, they will contact the Office of Public Guardian and Trustee and have a public guardian and trustee take over the decision maker. So a formal SDM. So the patient capacity needs to be assessed 21 days before discharge. So this is only in inpatient settings. So the Form 21 and Form 33 can only happen if the person's in the hospital. So now, once this 21 days is up, the Form 21 could be canceled, or the doctor can look into getting a community treatment order, or a Form 45, as we call it, and that can be issued. And then I will definitely get to any questions. I know this is a lot of information, and I did make sure I attached some links in the handout so that you're able to review it on your own. And this is important to note that this is based on a patient's experience. So if you are not admitted to hospital, or a loved one isn't ever admitted to hospital, this of course doesn't apply to you. And some people, they don't usually get to this point. Usually it's a Form 3 or so on, and treatment is provided. But in the event that you do receive or go through these experiences, it's important to know, and I did attach some links for your own review in the future. So now I'll discuss the community treatment order, or Form 45. So the Form 45, or the community treatment order, is an order to supervise treatment in the community. So this is usually given to persons who have experienced 2 or more admissions to the hospital in the last 3 years, and people who tend to abandon treatment once discharged from hospital, resulting in what we call a revolving door situation. And that looks like someone who constantly has to come back and be readmitted because they're not able to maintain their treatment outside of the hospital, or they have an increased risk of harm or self or others. And this also could be given to someone who had already had a community treatment order. And sometimes doctors or psychiatrists may give one a CTO, and then time lapses and a few years may pass, and then the person's admitted to the hospital again. The doctor may review that and say, oh, okay, this person has been on a CTO before. Perhaps this is something we should review, and get them back on the CTO. So the goal of the CTO is to keep the patient out of the hospital by wrapping community-based treatments and less restrictive supervision around them. So some examples of of wrapping around service would be like a assertive community treatment team or ACT team or a CTO management service. So with this, a CTP or community treatment plan is created with the patient, and it's a detailed plan of community-based treatment, care, or supervision that is less restrictive than being detained in the hospital. So they would create this plan, they would review it, the patient would sign off, cool, SDM, if applicable, will sign off, cool, we'll do this, and then you have to adhere to this treatment plan. Okay. The thing to note is the CTO process is very complicated. This is not something that happens, it's not a run of the mill every single day situation with every single patient. What we really hope is that patients receive acute care and treatment in the hospital. So when they leave the hospital, they're able to receive the supports they need. So the goal is to be able to attach them or refer them to services to help them be able to transition back into the community successfully and be able to maintain their mental health and wellness with the support of people, mental health practitioners, loved ones, etc., independently. This is mainly for people who cannot do so. So the CTO lasts for 6 months unless it's renewed by the doctor, and we'll go into that steps in the next slide. So as I mentioned with the community treatment order, the patient is issued a Form 49, and it's to let the patient know that the doctor intends to issue a community treatment order. Similar to the Form 3, they meet with the rights advisor to explain their rights, and it gives the individual an option to appeal the community treatment order. So if they don't appeal it, or for example, they lose the appeal, the Form 45 is given to the patient, and it details the conditions of the treatment order in the community. With this, a comprehensive treatment plan is developed. And as I mentioned before, it's involving the patient as well as their healthcare providers, their doctor providing their primary care, and they sign off on that and they go forward. So the CTO lasts for 6 months. The patient has to follow it for 6 months before it's reviewed. And then the doctor reviews it and they either end it or extend it for another 6 months. So they'll get another Form 49 once again. So this CTO is reviewed annually at the Consent and Capacity Board hearing. So a CTO cannot go on without any assessment for more than a year. So it's a year at a time. So in the event that, say, you do the CTO, everything is going okay, and then all of a sudden the patient just abandons it, says, I don't want to do this anymore. This sucks. Like, I'm just being honest. You get patients being, this sucks, this trash. I don't want to do this. I don't want to talk to the doctor anymore. I just want to live my life. I'm going to do me, whatever you want to call it. But they're on a CTO. So it doesn't really work that way. So what will happen is the doctor providing the care, the most responsible doctor, would issue a Form 47, and this person could be brought back to the hospital for further assessment and being placed on a Form 1. And this is mainly only if they're not following the CTO and there's reasonable concern for their health and well-being. So before I go into the case scenario, I just wanted to know if there was any questions. You can raise your hand. We do have a kind of a pretty comfortable group size-wise. So if you want to raise your hand and ask any questions about the material, and there will be an opportunity to ask after the scenario, but I thought I would, give an opportunity before moving forward. And if you don't have any questions or you feel more comfortable putting in the chat, go ahead and do so. And then at the Q&A section, I'll definitely answer those questions for you. Okay, so now in terms of the case scenario, if there isn't any questions or comments, I just want to make note that this, as a trigger warning, this is a conversation here about suicide or self-harming. So if you are triggered by that kind of conversation, again, mute your speakers, walk away, take a deep breath, and you can come back once we finish discussing this scenario. So here is the scenario. You noticed your 16-year-old sister has become more withdrawn and isolated. She is missing more school than usual. You sometimes walk past her room and hear her crying. You try to ask her what's wrong, but she gets annoyed and tells you to leave her alone. You get a call from one of her friends who says she is writing concerning tweets about not wanting to be in the world anymore. What do you do? Like, what would you do in this scenario? And I know it's very nuanced and it's very individual, I know what I would do, and it would be very different. But I'm curious to hear in the chat, like when you hear this, how do you think you would respond? And you can feel free to write in the chat or raise your hand and speak live. So like what do you think you would do first? Do you think you would confront the person? Do you think um you would have a conversation with the person? How would you do that? What do you think you would do first? Oh, someone said to start to have a conversation. Okay. So that's important, is to talk to the person. And as it mentions in the scenario, initially they might not want to talk. They might be like, get out of my room, leave me alone, mind your business. This doesn't concern you. You might say a bunch of those things, but you want to ensure that you make them know that it's possible that you're open to a conversation. So I think that's important. I don't know if I want to say your name because I don't know if you want me to. I think we're trying to work out some technical stuff over here. Just give us a moment. I think I did it right. Camilla, did I do it right?
Yes, sorry. Okay, you can share your screen again. Perfect.
Any other thoughts on the scenario? Don't be shy. There's no real wrong answers. We're all here to discuss and learn, and that's why you're here. Why I'm here. And as I mentioned, if you send it to me directly, I don't have to say your name. I could just say your comment. Try to talk to her first. Yes. I would really suggest that first, is, making attempts to talk. And, what we call it in healthcare is an open door policy. And it's being, and as the person says, it's being upfront and honest, creating a safe space. And that's exactly what I was going to say, is, letting the person know that you can come anytime to talk. I'm always here. You might not feel ready right now, but I'm worried about you, right? Creating compliance. Can you tell me a bit more about that, participant? I'm curious. I have a feeling of what you mean, but I don't want to assume. So while the person's writing, I'll go on and about that, about the safe space, because I think that's very important to have. And for individuals who are experiencing mental health challenges and concerns, sometimes they're bombarded by their own thoughts, and the thoughts are quite negative, and they tend to feel that they don't have a safe space, and they externalize that or project that onto others, that, oh, they don't care about me, or they don't have the time, or I'm a burden. And I think it's debunking or challenging those negative thoughts by expressing simply, I'm here for you. This is a safe space. I'm not going to judge you. I'm worried about you. I want to see how I can help. Um, and of course, it's doing a lot of monitoring, and it might not be to the person's, um, they might not feel good about the monitoring, but it's a good way to be able to understand how severe the situation is. And if you have to do a form 2, what that would look like. So I have the person, I'm just going to read what they said. I think that compliance, you and the other person, is important so that the other person will open up. So we should focus on both the verbal communication and the nonverbal communication. That's really important. With compliance, do you mean like rapport, like building a relationship, or like a connection, perhaps? Building trust? I just want to make sure that's maybe what you're saying with compliance. But those are all important points. Um, it's no problem. The person says that the English is not their first language. No problem. That you're right on. You hit the nail on the head. Is building. That's all a big important space. Is building a safe space for yourself and the person, and again, communication and observation is very important, and also not feeling like you're alone in the scenario. So like how that friend called you and voiced the concerns, it's reaching out to that friend and saying, if you notice anything else, let me know. Or maybe, perhaps they're safer to talk to you, but if you need help, I'm here. And again, it's asking another piece, is asking direct questions. And this can be very uncomfortable, but you want to understand the level of safety that you're dealing with here. Because if they're writing something that's serious online, again, you might have to take things in a little bit more in emergency matter. So one of the things you may have to ask directly is, hey, sis, I heard from someone that this is, or you might not want to betray the person, but you're going to want to be honest and saying, I heard this from somebody that you're having thoughts of, or writing about suicide, or writing about not wanting to be in the world anymore. I'm really concerned. Are you having thoughts of killing yourself? Are you having thoughts of harming yourself? It's being very direct with the questioning. And of course, people can always be deceitful, but it's looking at other ways of navigating it. Do you feel like, your mood has been lower than usual? Or, how has things changed for you? Is something going on in your life that you want to talk about? Maybe not with me, but we can go somewhere and you can talk to somebody else. Maybe a favorite aunt or godmother, or a counseling service, a family doctor, someone, a school social worker, whomever. But the point is getting the person to start to talk and have that conversation. And then from there, it's determining, do I need to do a form 2? Is that something that I got to do? And sometimes you might have to make that decision. So I hope this case scenario was clear. It provided some clarity. Just going to check the chat one more time to see if there's any more questions. So someone asked here, but how do you distinguish between when it is a cry for help or an actual thing the person is planning on doing? Is there a difference? I don't know personally if there's a difference. So, and I think that's where that stigma, where I talked about unlearning some of the conversations, or things that we've learned about mental health. It's breaking those things down, because in all honesty, if somebody is crying out for help by trying to hurt themselves, to me, it's just as serious as anything else. And I think it's important for us to have those conversations of the why. What's going on in your life that you felt that the only way you can get someone to pay attention or to provide you with support was to have such an externalized act, such a severe, potentially permanent act, because you can't take back suicide, right? Once you do it, that's it, right? It's unless you're unsuccessful. But if it's successful, then that's it. There's no way around that. So we want to try to be as proactive as possible to avoid that being their only way of alleviating the pain that they might be in. And the pain might be very temporary, right? It might be something that, and I've had experiences with patients where I'll use something very simple and minute. You broke up with someone you're in a relationship and you broke up and you just don't see that there might be somebody else, or you don't think that you're worthy or any of those kind of feelings, and you think, you know what, I shouldn't even be here anymore, and you make a very, what we call, impulsive or rash decision on a temporary circumstance. And if, luckily enough, the patient that I had, it wasn't successful, and we were able to have a very open and honest conversation and a lot of strength building for the individual to realize that, you know, there is more to life, and they will be okay over time. And it's allowing yourself to feel those emotions, which can be very difficult. So we'll get into that in the next slide, and that question about distinguishing between a cry for help, or the actual thing. And I'm using air quotes right now. So how we discuss it in healthcare is situational versus clinical mental health disorder. And it's remembering the same thing we talked about before: the thoughts, the feelings, behaviors, the life changes. And situational doesn't mean that it's not serious. It might just mean it's a certain point in time. So like I talked about earlier with the car accident, you're anxious because you're in a car accident. And now if you're anxious to go on the highway because you had a car accident. It's very situational. There's a very cause and effect there. Whereas with clinical mental health, sometimes there is no real rhyme and reason. Sometimes everything is going exceptionally well in your life. You have a beautiful family, you've gone to school, you have a really good job, you have great friends, you exercise, you're doing everything right. But chemically, you are depressed. You have what we call clinical depression. And that is something that would require maybe some medication. Not to say situational won't, but this might be a bit more longer term. As I mentioned before, it's looking at these key factors: thoughts, feelings, behaviors, major life changes. Somebody passed away. Of course, you're going to be sad. You may be grieving. You might be angry. You might separate yourself from people that you usually care about. But over time, with support, ideally, is those feelings get easier to manage over time. And then, of course, it can go into more complicated conversations. So when you're looking at a loved one, or even with yourself, it's really assessing those changes. I used to be X, for example. I used to hang out with friends all the time. I used to be a social butterfly. I used to want to hang out and go for lunch and brunch and all sorts of stuff. But I've noticed in the last month, I've just been super tired. I haven't wanted to have my friends around. I would ignore phone calls. I don't answer text messages. I feel like I'm a burden. And it's looking at all of these changes and then assessing and thinking to yourself, do I need help? Should I reach out? And who do I reach out to? So it's really taking all of those things into account when you are looking at someone who may seem like they're not themselves, and really trying to seek out if they need support or how to have those conversations. So that's the end of my presentation. I just want to see if anyone has any general questions or comments or thoughts that they would like to share in relation to the topic at hand. Again, it was my pleasure to be a part of this topic and presentation, and I hope that you walk away with a little bit more knowledge than you walked in with, a little more insight.
I just want to thank Nadeisha for your wonderful presentation that you put together today for us. And just to let everybody know that next week, April 10th, I almost said August 10th, I wish, if it was that hot outside right now.
We're hoping for it.
Exactly. And to be consistent. But April 10th, we'll be back here, same time, same place, speaking about taking care of yourself. So caring for yourself while caring for others. As you know, when you go on the plane, they say that you need to make sure that your mask is fit properly before you can assist anyone else. So we're just making sure that everybody's equipped with the tools and resources to help themselves while helping others.